We present a case of a 32-year-old patient with severe dysmenorrhea. MRI showed thickening of the uterosacral ligaments with a nodule along the posterior uterine surface contiguous with the rectus sigmoid. There was a full-thickness invasive bowel nodule measuring 3.2 centimeters in length, 8 millimeters in depth, and located 14 centimeters above the anal verge. A robotic approach was taken and the so-sure surgical technique was applied. ICG was first used to test tubal patency before suspending the uterus with a vicral suture. The left ovary contained a 3 centimeter endometrioma, which was drained and the ovary mobilized before performing left ureterolysis from the pelvic brim. With a rectal probe inserted, careful dissection was performed at the left uterosacral ligament, ensuring that the ureter was safely lateralized. The left endometrioma cyst wall was excised, taking care to preserve as much of the ovarian cortex as possible. Ureterolysis was then performed on the right side. The adventitia was kept intact to avoid compromising the ureter's blood supply. The nodule was dissected off the right uterosacral ligament and torus uterinus using a combination of blunt and sharp dissection. The rectovaginal space was carefully opened in the correct plane in order to fully mobilize the bowel. At this stage, we suspended both ovaries bilaterally with a PDS suture. A rectal probe was reinserted and further dissection was carried out, entering the pararectal space on the right side. The hypogastric nerve was clearly identified and preserved bilaterally in this case. The remaining right uterosacral nodule was excised, ensuring the appropriate depth was removed, leaving only healthy tissue, as seen here. Moving to the left, the same dissection was performed, preserving both the nerves and the mesorectum. The principal robotic instruments used were the forced bipolar forceps on the left and the monopolar scissors on the right. The third arm, the Cadier forceps, were used here to apply traction on the nodule in order to aid dissection. Turning to the bowel, the size and the consistency of the invasive rectal nodule can be appreciated here between the robotic instruments. A vicral stay suture was placed at the epicenter of the nodule to help anchor it into the CDH stapler. In this case, a 29 millimeter stapler was inserted into the rectum, and using the suture, the nodule was positioned between the open arms of the stapler. With the nodule stabilized and ensuring no surrounding healthy tissue was incorporated into the stapler, the colorectal surgeon anteverts the instrument before closing the stapler to resect the anterior wall of the rectum. Upon removal of the stapler, it is evident that the bowel was not under any undue tension or twisted. To reinforce the bowel wall, 3 interrupted vicral sutures were placed along the staple line. To conclude the procedure, a Michelin test was performed, and the team also injected ICG intravenously to confirm good vascularization of the bowel wall. Hemostasis was confirmed, Perclot adhesive powder was applied over the dissected areas, and the uterine suspension was released. Blood loss was minimal, and the procedure time for this procedure was less than 2 hours.